So thank you everyone for tuning in today to our virtual community of practice discussion on how the emergency departments across the country have been supporting people experiencing homelessness this winter. Um, this session is being co-hosted by the CAEP Health Equity Working Group, the GEM Center, as well as the UofT DFCM Social Accountabilities Leads. I'm going to be moderating our session today. My name is Marcella Jones. I'm an emergency physician at University Health Network in Toronto and also practice some addictions medicine there. I'm a member of the CAEP Health Equity Working Group as well as the GEM Center. Elena, next slide, please. So just going to give a quick overview of the session as well as some brief introductions to everyone speaking today. So I'll give a little bit of context up front for what has kind of brought us all together. And then we'll move to Hamilton, where we will be hearing from Megan Lynch, who is a nurse and senior manager at the Greater Hamilton Health Network, as well as Jen Bonner, who is the executive director at the Hub in Hamilton. We'll move next to University Health Network in Toronto and hear from Dr. Kate Heyman, who is an emergency physician and the medical director of the Toronto General Emergency Department, Nick Herman, who is a PhD researcher at the Gattuso Center for Social Medicine at University Health Network, as well as Tracy Warren, who is the lead community health worker with social medicine at UHN. We'll next move west to Edmonton, where we'll hear from Amy Mombourquette, who's a social worker at the Royal Alex in Edmonton, to hear about what they've been doing to support this population this past winter. And then hear from Dr. Louis Hugo Francescuti, who works on the Bridge Healing Program that's also in Edmonton. And then lastly, hopefully, our goal is that there's lots of time for questions and discussion at the end of the session, because I think ultimately we're really excited to hear from each other and really hear how we've been supporting this population and get some ideas for next year. Next slide, Elena. Thanks. So just a quick backgrounder, the CAEP Health Equity Working Group has sort of existed at CAEP since 2019 and broadly works towards advancing health equity and social emergency medicine in our clinical education and academic environments. Next slide. The GEM Center is at University of Toronto. It's the Center for Global Equity in Emergency Medicine and is focused on looking at education and research initiatives that advances equitable emergency care for all. Next slide. Okay, so some context. So the idea of this kind of collective debrief kind of came together. We use debrief all the time in emergency departments. We use it as a tool to process, reflect, and learn from difficult and challenging cases. Well, this past winter was pretty challenging one, particularly out east. We had a really, really long, really cold winter, and we saw the numbers of people experiencing homelessness continue to grow. We see it in our waiting rooms every night. As the shelter capacities are really sort of at and over their maximum in many respects. The emergency department is a place is and always will be a place where people experiencing homelessness will seek warmth and safety. And so what we wanted to do is have some space now that the winter is kind of coming to a close to check in with folks across the country and debrief what happened this winter in emergency departments across the country. We want to hear what different emergency departments were doing to support this population, what went well, what maybe went less well, and what opportunities we can improve on for next winter. So without further ado, we'll move over to the Hamilton group to hear from them. So Elena, next slide. Thank you.
Perfect. Thank you. And we have a tight schedule, so I'll get right into it. Thanks so much for giving us time today. I'm Megan Lynch, pronoun she, her, a senior manager with the Greater Hamilton Health Network, so the Ontario Health Team. And I'm joined today with Jen Bonner, the ED of the Hub. So I'm actually speaking on behalf of our two hospital partners as well, Hamilton Health Sciences and St. Joe's Healthcare Hamilton, representing three different ER departments. So this is the second year we have ran this hospital discharge warming hub, and it really came out of needing a location to discharge to from those who are experiencing homelessness, so either ED or inpatient. The shelter systems are full. We had one ER reporting last year that every 2 hours an individual was discharged who was experiencing homelessness. In Hamilton, a hospital staff would have to call every single shelter, there's multiple shelters, or drop in space to find a space. So the solution became taking funding from both of our hospitals, one from a hospital foundation, one directly from the hospital, as well as the Ontario Health Team, to fund this space that are operated and funded and staffed by the hub. This allowed one phone number to be called from our hospital ED staff between 10 p.m. and 7 a.m. We ran it from mid-December till the end of March. And the reason that they could call was timing. It was not for space. We didn't want all of the ERs sending people all at the same time to ease of sight. So there was room for them. We just didn't want them to just send. We wanted staff that were receiving to be ready for the clients. So the winter hub was staffed by medical and police students. So these were students that could have a valuable insight into the individuals that they will care for when they become either police officers or doctors. It was also staffed by volunteers and paid peers with lived experience. Unlike our municipal warming hub, we did not use security and police. So in a lot of the Hamilton media, they talked about a lot of the budget needing for policing and security. That was not the case with our hospital warming hub. Clients were treated with respect and dignity. Boundaries were set right from when they arrived. They were reminded, and clients were mostly respectful, but just so appreciative of having this space. The client surveys, which we'll talk to later down, will actually make you tear up. So this is not an emergency shelter. So it's not operated with municipal money. It was funded by the hospitals and the Ontario Health Team, but it's simply a space to warm up overnight, get food, something warm to drink, and a space for people to sleep if they wished. So our hospital staff in Hamilton are fabulous, fabulous and dedicated. They didn't need to do anything differently in the ER. They simply needed support from our community of where to send the individual when they no longer needed care from the hospital. So through advocacy and with hospital staff knowing a discharge to shelter was not always working, we needed to do something different. So you can go to the next slide. So what worked well? As the outsider and the funder, I would say this staffing model. So we have seen so many other models staffed. I work with our homeless serving sector partners quite closely. The hub built this great staff model, trained them, respected them, and it really was a key to the success. On nights when the hub was over capacity, they were able to pull in more staff and volunteers just because everyone was so committed to the teamwork. It was a non-authoritative approach versus some of the other models in our community that had many, many more participants without the incidences that were reported at some of our municipal emergency shelters or drop-in centers. Peers made a difference. It was located in the downtown. So in Hamilton, we call it Ward 2. It was close to services that individuals were already aware of. It was halfway between two of our three ERs. It was a large room. There was washrooms. There was a separate entrance. And there was a designated space, like an office space. And as the Ontario Health Team, I really want to brag about all the referrals. So when clients were in this space, they felt safe. They accessed wound care. They accepted referrals to housing. They accept many, many referrals to primary care through our shelter health network doctors and clinics. Two of the doctors even gave out cell phones, emails for direct follow-up. 10 of the clients were able to start on opioid antagonist treatment. And then we had one of our outreach nurses from our hospital substance use team who changed their schedule and actually came on site at 5 a.m. to 7 a.m. to start doing some follow-up with the clients there. So numbers speak for themselves. Over 102 days of operations, there was 5,202 visits. So that is 308 unique individuals, and 346 of those individuals came directly from hospital. So the space was open for participants in the community. So they might have been in hospital earlier that day, earlier that week. and they did not need to go back to the ER to get a referral here. They were allowed to come into the space. It was a warming center for all. It was just priority were given to those hospital discharges, especially because our hospitals funded 2/3 of the program. So of those hospital discharges, that's 346 times ER staff knew where their patient was going to go somewhere warm, safe, caring, and that they could receive that follow-up care. We had one ER director reach out to me and say, it's great. We know they'll follow up with wound care. We know they'll have access to that primary care. We really support and appreciate this program. There was 70 calls made by the hub staff to shelters to find beds for these clients. And of that, there was only 10 beds secured. So if we had a hospital staff spent their whole night shift making all those calls, that takes them away from direct patient care that they would have been able to provide to other patients. So again, we think that's a huge success. So next slide, please. So there's always some challenges with success. So this was our second year. And in our second year, we didn't have the building we were able to use the first year. So we had to find a space. Conversations started last April, working with our municipal partners, trying to find an appropriate space, but the community didn't want it. They did not want a congregation of unhoused in their neighborhood. So it was a long, hard road. The hub has operated both, first in their location and then now at the second location because they moved over the summer. We tried really hard to work with our municipal partners who already operate our other shelters and drop-ins to find a mutually agreeable space. Ideally, we were looking for free because that's what we had operated before, but we did end up having to lease space. So another kind of challenge was our shelter partners who were funded to do this work started to use this as an overflow. So if they were full, they would send their clients, which takes away from the hospital discharges, especially if they didn't call ahead of time. So one evening, multiple people, multiple taxis were showing up and the staff were not aware. And it was hard to communicate with all of our hospital and all our community staff the purpose of the safe space, that it wasn't just another emergency overflow shelter space, that it really did have a medical component and it was geared towards our medical community. The other challenge is this is temporary, right? So we build it up in December. Once we scrape together the funding, get staffing, we operate it till March 31st. And then it ends. And we live in Canada. The weather doesn't just all of a sudden April 1st, oh, it's nice out, that's fine. So it's still cold, there's still snow, and there's unfavorable elements. Also, so not a challenge, but I wasn't sure where else to report this. I want to highlight the difference between this program and the staffing model compared to some of our other municipal staffing models. That spent 70% of their budget on police and security, where this had no police. There were 3 calls. So out of 5,202 people, the police were called 3 times. And there were 5 calls for paramedics, 2 overdoses on site, and 3 other health concerns where the individuals need to be sent back to the ER. And yeah, so that really is a success, but we'll put it under challenges. And next slide. So even though our staff super, super busy, they felt the need and the importance to do a client survey. So tell us what you liked about the warming hub. And these are the ones that make me teary when I think of some of them, of really what these individuals would have to do for housing or somewhere warm to stay if this hub wasn't there. It was like 98% overall satisfaction rate of the warming space, where I don't know if you guys have evaluated any programs, nobody ever gives that high of rate. There's always something to complain about. These individuals were so appreciative to have somewhere warm to go, where they were respected, where the staff didn't treat them like they'd automatically done something wrong because they were there. I think that speaks to the true value of the program. And last slide, please. So where are we going to go from here? And again, so it's April. We're trying to meet with all our municipal partners. We're trying to pull everyone together. Um, Jen and another partner delegated to our city council. We're seeing from our business associations, our neighborhood groups, even our public libraries, that they want a solution. Um, Jen and I are planning to do a roadshow to provide these stats and this limited funding in which this program was able to operate compared to some comparables. We really want to present the data and the outcomes, but most importantly, the impact stories from the clients themselves through the client surveys. And this program really would not have been possible without the hub's ability to run the program the way they did, have the connections with the population. So they staffed it with people who were known to the clients. This fostered respect. This fostered a community program, not a service. All the staff had a trauma-informed care lens, a first-person approach. So personally, my dream is looking at a dedicated space that would be 24/7, not having individuals at a library during the day, then moved into another drop-in, then moved into another space in the evening. We want individuals to feel welcomed, that they can actually decompress and start thinking about what their needs are and their next steps instead of how they're going to survive the night. Um, and everyone needs to get a Jen in the hub in order to operate a program like this. So thank you so much for your time.
If I could just talk briefly on the staffing model, one of the things that we did that was really special is that, for the record, been doing street outreach here for about 30 years now. So know those folks in community that hold high social capital, whether that's an outreach worker from another team, from another agency, it's an Indigenous worker from another agency. And we offered all of those people an opportunity to come work for us at this program. So although they worked for other agencies, they would pick up shifts with us. And so that it looked very collaborative to clients as well. Who's the person you go to most? We asked those questions and then we went out and recruited that staff as peers to join our team. And it really made a difference in people feeling comfortable to ask for those things and for those linkages back to community associations.
And thank you for the time today. That's all we have. I know I went slightly over, so I appreciate that.
Yeah, thank you so much. Really great to hear about your experience, and just capping off sort of what Jen mentioned around like the importance of community and relationships, and like really sort of like as the glue that kind of like held this all together and made it all work. So that's wonderful. Hopefully, we have some chance to talk more at the end of the session. Next, we will move on to University Health Network in Toronto, and hear from the group there. Thank you.
Thanks, Marcella, and thank you, Megan and Jen, for sharing your experience in Hamilton. So in Toronto, just to situate things a little bit, the City of Toronto winter programming runs from November 15th to April 15th. So our service aligns with those dates. The city shelter system is consistently without capacity, and the city opens additional emergency warming spaces at -5 and then additional sites at -15. This winter actually had much lower than typical numbers of unmatched calls because it was so darn cold in Eastern Ontario. So city did have more capacity than they have had in previous years. And all of the matching happens through a centralized intake system in Toronto. That lack of system capacity is what led us to, in collaboration with TNG and with the Gattuso Center, open the winter support service initially 3 years ago. So this is the third year that the space has run. There are 15 spaces, mostly recliners, and a couple of stretchers where people can stay for 5 to 14 nights. The space provides a warm overnight space for people experiencing unsheltered homelessness who are being discharged from hospital. Most of the referrals come from the emergency department, although some referrals from general internal medicine. The goal of the space really is to provide an opportunity to connect with the social medicine programs that UHN's Gattuso Center runs, as well as community resources, to reduce the impact on the ED waiting room, particularly reduce ED length of stay for people who are unsheltered during those periods of time when it's not actually safe to discharge someone from the ED with nowhere to go, and then to support some longer-term transitional stays. It's staffed by peers with a shift lead, and there is a community-based security guard in the space as well. And the peers who work in this space from TNG also have a longstanding relationship with the emergency department, which also staffs peers from the same organization. Next slide, please. So this past year, some of the things that went well, the program, is in a more mature state. So particularly in Toronto, where the shelter and emergency warming system is complex, there was a lot of confusion from staff in the first couple of years. And people now kind of know this is the UHN affiliated space. It's adjacent to one of our two sites. It's right beside Toronto Western Hospital. And so there was a much better sense of what was going on with it. Thank you to the hard work of the social medicine team, particularly Allison. I'm not sure if she's on the call. We had integration into our EMR. So referrals could be made in Epic, which was also great because patients, because they could stay there for consecutive nights, we could actually see if they had an appointment at the space that night already booked, which helped reduce a lot of confusion if people maybe couldn't clearly verbalize where they were staying or they weren't sure if they had an opportunity to continue to stay in the space. In the first year that we ran the program, people needed to come to the ED every night to gain access to the space. That model changed for year 2 and remained changed for year 3. So we didn't see a pull effect where people were accessing the emergency department specifically to access this emergency warming space. And we did see mitigation on ED length of stay. So when we ran the data in our first 2 years, when we had a model that didn't require an index visit, and was open for ED referrals, we did see reduction in ED length of stay related to this space. We have not yet run the analysis for the 3rd year, but most of the referrals actually come from the Toronto Western site, which is beside the space rather than the TG site. And we can see that for every month of the winter, with the exception of January, there was a shorter 90th percentile ED length of stay for people experiencing homelessness at the site referring to the winter support space than our other site, which almost serves as a control because we'll get into one of the limitations. Just to move a couple of kilometers from the core of the downtown to the Toronto Western site and the adjacent winter support space actually feels like a long ways for people to go. Although the Toronto Western space and the winter support space are still very much in the core. I'll turn to my colleagues, Tracy Warren and Nick Kerman, to talk about some of the successes from their perspective.
Thanks, Kate. I just want to speak briefly to the strong collaboration between the ED social workers, the peers at TNG, and the social medicine community health workers. There was a real commitment from all parties to support the best possible outcomes for our client group. One example of that, one sort of basic example of that is, the ED working with the peers to provide accompaniments from the hospital directly to the winter support service. They could then facilitate soft handovers, make people feel comfortable with someone that they've already got a trusted relationship with, and also provide those next step recommendations, as well as refer to the community health workers at that point. Nick?
Nothing to add at this point. We'll talk a little bit more about the evaluation findings from patient perspectives in just a moment. Next slide, back to Kate.
So in terms of some of the challenges, in contrast to the hub model, everyone accessing the space did still need an index visit to the emergency department or GIM. So it's not a true diversion program in that patients who had no identified medical needs can't just pop into the space. And it still has some of the hours and time of year limitations as well. So again, space closed April 15th. April 16th, there were a number of folks in the Toronto Western waiting room who shared that they had been staying at winter support. And despite the extremely concerted and dedicated efforts of the folks at the WSS, people still ended up coming back to the hospital as a place that they trusted and connected with rather than going into the city system. As mentioned, patients still reluctant to go from Toronto General. That couple of kilometers still feels like a long way, particularly if people are using the ED waiting room to bridge for just a short period of time overnight. And those shoulder system challenges and just reflecting on the comments from the hub, One thing that we don't have access to in this space currently is that 5 a.m. to 7 a.m. provider touch point. What a dream. So maybe some idea generation there already. And I'll turn to Tracy.
So sorry. I thought this was your part, Nick. If you want me to jump in, I can.
I'm happy to briefly talk about this. This is both information that has kind of come up both in terms of experiential operations as well as things that we have heard from an evaluation perspective. And so there are some accessibility barriers associated with the shelter system, and the linkages to the WSS remain accessible for many, but there are some individuals that just feel like this space doesn't work, and or I like this space a lot and I don't feel like I can make a transition to the shelter system. And so there can be a little bit of a blockage at times. And then there are some feedback around certain facility limitations, the lack of showers, concerns about ventilation, that I will touch upon in just a moment. If you can go to the next slide, please. So now in our third year, this is the first year that we really kind of dived in and started to collect more data from visitors about what their experiences are, not just at the site itself, but kind of coming into it, and their perspective on how that has impacted their lives, particularly in the short term. And it echoes a lot of what Megan talked about as well in Hamilton. With regards to this being kind of the salient experience, people are describing a really smooth transition. Oftentimes, like Kate mentioned, it's across the street at the Toronto Western. They're not going far. It's an easy transition. They are transitioning or coming to the WSS with a fairly limited understanding of what the WSS can do for them. So there's not a lot of expectations. Really, what it is people feeling fortunate to have somewhere to go. There's a real sense of hopelessness in Toronto about accessing the shelter system if you're outside of it. And so people really appreciated that folks in the ED or elsewhere in the hospital could make that referral, and in very quick succession, they could access this site. When they were there, they really described a safe and a welcoming environment. Contributing factors to that were that it's a small open space with good visibility, sight lines around the program space. The other thing is, as Kate mentioned, it's about 3 to 4 staff on site for 15 individual capacity. That's about a 5-to-1 staff to visitor ratio, which is pretty unparalleled in the shelter system in Toronto. And so really noticing that staff presence. And then that really was the big story for visitors, is who was in the space. I've been doing research about service experiences of people experiencing homelessness for about a decade and a half. And time again, we hear this adage. That almost instantaneously, when accessing a service, an individual or service user will make a distinction between a service provider that's in it for the money or in it because they care. And it's a really important distinction about who they feel they're being supported by. And ideally, it's both, right? People getting a living wage, and they're doing it because they care and they like the work and they feel connected to the population. Sure enough, in this evaluation, same adage came up, and people are talking about how much staff care. And so really highlighting it's the right people delivering this intervention, not just in terms of the tangible supports that are being provided, but the emotional support that comes alongside of it. And if we look at the impacts, I think one of the things that people highlight is just the acceptance and validation. And I think, Megan, you talked about this as well. Most people that we interview had negative experiences in hospital, often with security being escorted out of the building, or in some way communicated that you're not welcome here. And so to come into this space, to be accepted for who they are and what their needs were, there's a real sense of like psychological understanding and validation that people reported. Other benefits that we heard about were really derived from that sense of safety in the program. So improved sleep, not having to sleep with one eye open around belongings. I don't think we heard from anyone that they had experienced a theft in the location. So a big contrast compared to the shelter system. Reduced victimization in comparison to the shelter system, but also the potential of being unsheltered in Toronto. There were some concerns about respiratory virus transmission given the small space and observations of people coughing and those sorts of things and the ventilation concerns. And then also people talked about a reduction in substance use because they weren't on the streets, they weren't using to keep warm, or one individual very interestingly kind of said, I wouldn't come here and use because I respect the staff, I respect the space, and so really feeling connected to what the value is and how they will present in that space. And then last one, a really notable challenge that persists is just for people that are able to stay 5 days or with an extension of longer, some worry that despite that, it's not long enough to find access to a shelter bed that works for me. And so that's just something that we heard from some visitors as hanging over their heads. I think that's all for us.
Yeah, awesome. Thank you, Kate, Tracy, and Nick, for presenting about Toronto's winter support service, which is again kind of connected with the University Health Network in Toronto. Okay, next we're going to move west to Edmonton and hear from Amy. Thank you.
Yes, thank you so much for having me. So yeah, I just wanted to touch base on three new initiatives that Edmonton is implementing to reduce the overflow within our emergency departments. But I do think it's valuable to kind of touch base on some of the social landscape currently of Edmonton as it directly affects our capacity issues and our overflow issues. So I chose four. There are more, but I chose four to focus on. So the first one is we did have a large closure of our women's only shelter. So the Community of Hope shelter closed its doors, which is 96 spaces this winter. And this shelter specifically um, sheltered more than 3,400 people during its 2 years of operations. So right now we're seeing an increase of vulnerable women who are now displaced and accessing alternative forms of accommodations, including accessing the emergency department more frequently. Social work specifically has seen an increase in domestic violence presentations as well amongst vulnerable women, and domestic violence shelters continue to remain limited here in Edmonton. The second one is we implemented an encampment response team a couple years back, which is continuing to happen. So they are continuing to kind of dismantle the encampments that a lot of our vulnerable populations reside in. In response to that, they have opened a resource hub. However, that doesn't technically address the sheltering issues that we currently still have. We also had a large increase in frostbite injuries amongst the houseless population, which we're also seeing affecting our ED capacities as well. And we did have one of our closures of our safe consumption sites at the hospital to remain in the city still, but we're probably seeing some effects of that regarding our opioid overdoses that are coming into the ED as well. So yeah, we can go on to the next slide on one of the initiatives that's come out of kind of the 90-day plan that has been implemented to reduce the overflow that's happening at the Royal Alex. So we have now a Hope Mission, it's called the Hope Mission Navigator. So it is a 24/7 outreach worker and supported transport model with the Hope Mission, which is a community agency that's quite well known in Edmonton. And the focus is for patients with primary social needs to be safely transported once deemed ready to be discharged from the emergency department to a community agency of their choice. So what gets provided is real-time engagement in the emergency department. These outreach workers are there 24/7, building relationships, building rapport, and ensuring that these individuals leaving the emergency department, especially in the winter hours and days, are kind of safely transported to whether it be shelters, clinics, day programs, or the navigation center, as I previously discussed. This is new, so these numbers are new, but the service is definitely being utilized. So we've had 396 transports in December. March was our highest of 977 transports, and April is projected to exceed March. So far, 3,400 patients have been transported to safe community agencies after they've been discharged from the emergency department. Most of these transport destinations are around emergency shelters, detox, and medical respite. We can do the next slide. So the second initiative, which is currently the team that I am on, is the Edmonton Corridor Emergency Department Frequent Visitors Program. So we are modeled after the Calgary Zone Emergency Department Frequent Visitors Program. It's a mouthful, but we're modeled after them. They've been in operation for about, I believe, 8 years. And what this is to coordinate, develop, implement, and maintain ED exceptional care plans for high utilizers, high risk, and complex patients across the Edmonton corridor. So the team that consists of registered nurse, social worker, medical lead, clinical nurse specialist, and a recovery Alberta nurse, which is Alberta's addiction and mental health pillar. So out of 500 of the most frequent visitors of the Edmonton Zone EDs that have been identified as requiring exceptional care plans and or care coordination services with community and outpatient services. So out of these 500 high frequent visitors, 68% have been identified as unhoused, with majority presenting to the Royal Alex as their primary site, as we are the inner city hospital. So a lot of our vulnerable population accesses our site. So with this, what is working well, which is aligning with our goals, is it's increasing collaboration with community stakeholders. So we're working with primary care providers, outpatient services, Recovery Alberta, shelters, housing operators, and cultural services. We're also able to identify gaps in increasing continuity of care in community and ED settings to improve patient outcomes. We're also doing some effective care planning for this population, which we're trying to involve the addiction and mental health pillar a little bit more. And in regards to more of since this team, unlike Calgary, has a social worker on their team, we're able to do a little bit more case management. So my main role is to connect the frequent visitor to more community supports that are going to gain better health outcomes. So as some of them that I said around primary care providers, outpatient services, things of that nature. Areas of improvement. We're slowly building our collaboration with Recovery Alberta, and I think that would definitely strengthen our care plans. If we're kind of looking at it from more a holistic lens, this is definitely not a one pillar model. Also improved communication, since we have unfortunately re-separated back into pillars. We're now starting to have to kind of build those pathways again to ensure that continuity of care is happening, as well as communication regarding care planning. And also it's a very high caseload. I'm sure once we're done the 500, we're going to get another 500 patients who require a little bit more care coordination in the community. So our team is small, but hopefully room for growth there as well. Okay, and the third is the next slide. So the second initiative that came out of the 90-day action plan was the implementation of 24/7 social work in the emergency department. So we are currently, it's ongoing recruitment. Night shifts have been difficult, but to kind of maintain that coverage. But the purpose around that is to increase visibility of social worker in the EDs. Um, Most importantly, to probably promote safer discharges to community. We see often that people are put into unsafe situations, proper assessments aren't done regarding risk screening, things of that nature. So the more social work, I think the safer our vulnerable population will be. There's also that ability to shift for more of a solution-focused intervention when we're involved with individuals in the ED to more of a comprehensive social work interventions. So we're able to kind of do our biopsychosocial assessment, understand the individual a little bit more, and hopefully reconnect them to services and supports that will help them. And also, we've heard a lot of good feedback from nurses that it alleviates a lot of the stresses that they face in regards to having to problem solve these very complex social situations, given how kind of busy it is over there as well. So with this, it also allows us to continue our advocacy work. So we are already identifying and having meetings with kind of right now we have some of the health ministers over at our site. So we're kind of highlighting the gaps in detox capacity, where we would need more detox beds, just the prolonged wait times for residential substance use treatment and recovery programs, highlighting the need for more appropriate supportive housing options, the need for more low barrier emergency and transitional shelter spaces. Um, there's a lot of strong advocates for more dedicated supports for single women experiencing domestic or gender-based violence. Also, there's limited capacity within shelters to safely support high acuity individuals with complex medical, psychiatric, behavioral needs. So we're hopefully can bulk up the supports in those areas as well. And then one of the main ones is to improve pathways through our Alberta support system in regards to financial support, emergency medication coverage, and emergency short-term accommodations as well, which those are sometimes the three main areas that would impede a quicker discharge from the ED. So yeah, those are the three things that we're trying to work on over at the Royal Alex. Thanks so much.
Thank you, Amy. Next, we'll move to Dr. Francescuti, who is going to be sharing some experiences at the Bridge Healing program. Thank you.
Yeah, I think this must be just a title slide because I didn't send slides in. I'm not going to have a PowerPoint presentation, so hopefully that doesn't make me powerless and pointless. What I want to do is emphasize something that I think is going to be revolutionary, and in the sense that it doesn't require shelters. We take patients from the 5 different emergency departments in Edmonton, and if a bed is available, we send them directly to a community-based organization called Jasper Place Wellness that in partnership with us is building 12 bed buildings. They sit on a single lot, 3 stories. The city of Edmonton is providing free land, and the current mayor has made a commitment to having a bridge healing building in every neighborhood in Edmonton. There's over 300 distinct neighborhoods. And so, probably within the next 4 or 5 years, our goal, and the meeting I have right after this is to continue that work, is to have every neighborhood reach out and say, we want one of these healing houses, and we're going to welcome these 12 individuals into our neighborhood, and we're going to support them to become integrated within our neighborhood as well. So, we have 36 beds right now that are harm reduction, so 3 buildings. We have another building that's sober living, 12 beds. We've got 2 new buildings that were a bus turnaround about 9 months ago. And in July of this year, we'll have 2 brand new buildings. One of them will probably be dedicated to women only. We've got another 24 beds in Parkdale 2 that's construction's going to be starting soon. The city's given us two other lots in Calder and another lot in Highland. So we'll have another 72 beds, hopefully within a year's time. And then we have 12 more lots that the city has identified that we're going to keep building on. The Royal Alexandra Hospital Foundation has made a 3-year commitment of $10 million, dollars, and we've been able to leverage operating dollars out of that and leverage some federal building dollars so that we can continue to build and not use those dollars for operation. We run at about 105% capacity. If a bed empties in the morning, it's filled by the afternoon. The philosophy is the Eden principle that if you put 8 to 12 adults together and you give them a door that they can lock, all the things that you described are happening. People use less, people, their lives are recovered. Those testimonials you saw are the ones that we see as well. One thing you mentioned about fresh air, we have heat pumps in our building that change the air in the building 6 times an hour. A hospital doesn't even do that. So the long and short of it is we're trying to be very disruptive and eliminate the needs for shelters by building beds within a community and have the community provide the support. And we also have our own community health center that provides the medical needs. We've developed two AI chatbots that do the intake process, and all the information that's gathered is populated into the data management system, and it monitors the progress as well for these patients. And I have a PhD student working on developing a complexity score to just figure out how complex these patients are. Because I don't know if you know, but at least we know in Edmonton, 33% of the patients that present at the Alex are unhoused. And we also know that 1 in 5 will be dead in the next 5 years. So 20% of the patients that we see that we diagnose as being houseless in the next 5 years will be dead. So there's a lot of really good stuff happening. Amy talked about the stuff that's happening up front, but behind the scene, what we're doing is trying to be very revolutionary in having a healing house in every neighborhood. And if we do that, we pretty well eliminate homelessness in Edmonton. So Edmonton's the fifth largest city in Canada. It's also the most northern city in North America. And I think it's a model that can be replicated in other places as well.
Thank you, Louis. I'm curious. You said that the bed fills up basically right away. What does that look like from the emergency department to Bridge Healing? Like, could someone from the emergency department get discharged to a space at Bridge in the same day?
Yes, they go directly if a bed's available. The only trouble is we don't have enough beds right now, so the beds fill up very quickly. But as I said, we've got so many buildings on the go right now that it becomes easier and easier. And there's no time limit for individuals in the building as well. We used to have 90 days. We found that that doesn't work. You've got to work and meet the people where they're at. And that's why we're building our own buildings in the community so that as they come out of Bridge Healing, there is a place that they can go to. So that's the model that I think is going to be exciting, where a community says, build one here, and then we rally the dollars that are required to build it. And then we have a community partner that provides the support. And now we're looking at having folks with lived experience actually managing the buildings themselves.
Thank you. Elena, can you just move to the next slide for us? Thank you. Wonderful. So thanks. It's really exciting to hear about all these different programs that people are doing to support this population across the country. We have about 10 minutes now for some discussion and shared learnings. The cherry blossoms are out in Toronto. I think, this is like this like hopeful, this spring is now here, but I think, our goals are really to look ahead to next winter and see how we can start our planning now. So I do know that we have a couple folks on the call that didn't sort of give us formal presentations, but I suspect they have some some things that they may want to share from their own hospitals or emergency departments. So just I'm going to give a little bit of space if anyone else wants to kind of jump in and share what they're doing at their site and take questions as well. Thank you.
This is Britt Bailey. I'm a emerge physician and addictions physician in Kelowna, out in British Columbia. And Marcella had just asked if I could speak informally about a couple interventions that we do locally. So I'll just say briefly, we have a couple things that I think are mimicked other places in the country, but are interesting sort of pop-up ideas. One of them is a warming bus that is activated at a certain temperature. It kind of changes per year what the city determines meets threshold, and has a flexible route that often involves the hospital. And we can discharge directly to the warming bus from the emergency department. There are some rules around it, how long people are able to stay on or how many loops of whatever route they're doing. But it's something that's flexible and just comes into play on cold nights. And then the second thing is a in the department role that we have. We're a fee for service emergency department, and we're the second busiest department in British Columbia. And we have implemented a per hour compensated physician role called the emergency department physician lead, for which one of the key goals is to see patients that are more complex or have more complex social issues or addictions issues, to allow the emergency physician provider time to try to properly address some of their concerns in a more holistic manner. And that runs from 8 a.m. to midnight, and also involves allowable handover of patients, such that if you are working until 2, 3 in the morning and you have a patient who you'd be ultimately discharging out to the cold with foot cellulitis in a really suboptimal situation, that you can hold them in a bed overnight for the morning physician to assess them and discharge if you have any semblance of medical indication for that, which has sometimes come in handy on cold nights. And then lastly, I just wanted to comment that the discharge into the cold is one of the most dreaded things that I do in my job. Even though we have all kinds of difficult elements of our job, discharging to the cold feels awful. And so I really appreciate this discussion and seeing the ideas that are in place across the country.
Thank you, Britt. Thanks so much for sharing and for telling us a little bit about what's going on in Kelowna. Okay, does anyone have any questions? Hand from Jen at the hub.
So just something to think about. I've heard a lot of conversation here around the cold alert protocols in many municipalities where warming centers are not activated until a certain temperature is reached. 2 years ago, we did some advocacy here in Hamilton. We no longer operate on a cold alert protocol. With our partners at Public Health, we had lots of conversation around the fact that it's still really cold for people at zero when they've been sleeping outside for many months. And so it came from an emergency situation where our warming centers didn't open on Christmas Eve because the temperature had fallen just below the protocol, in which we went out publicly on our social media and announced that we couldn't open, even though we opened. City was a little embarrassed by that. We were funded that night by the community. Community pitched in and paid for staff to make sure that we had people. And now they have decided that we have winter warming supports from December 1st until March 31st. So there is some advocacy through public health departments and teams to have that cold alert removed. And now that is the standard practice and has been for the last 2 years. So just something to think about where in your individual municipalities that advocacy can happen to address the cold alert protocol. I think it's a really important piece and component of this, that we're not just activating because it's minus 15, because to the people that I serve, minus 15 and minus 2 feel exactly the same way. And so, yeah, just something to think about in terms of advocacy pieces that could be done.
Marcella,
Yes.
I'll tell you there's an opportunity here because I do a lot of talking to people across the country, and communities are all feeling this. and not knowing what to do. And I think collectively, this group here, even if we were to take everything we've done and just feed it through ChatGPT and say, here's best practices, and then put that out there. So if we do a best practice model and communities are not doing it, then they're going to have to answer why they're not doing it. And as a matter of fact, if you want to be really bold, um, I started this and then I dropped it. We should make a public statement that Accreditation Canada has a standard that no patient should be discharged to homelessness if they show up in a healthcare facility. So can you imagine if somebody shows up in a healthcare facility and they're homeless and there's a standard, an Accreditation Canada standard that says that patient cannot be discharged? Then all of a sudden you'll see politicians and healthcare systems paying attention. But because there's no consequences now, they continue to do it. So I think CAEP should have a position statement that says, we do not believe, and as a matter of fact, the Alberta Medical Association section on emergency medicine gave me such a statement that I used to do what I'm doing. And the statement says that no patient that shows up in emergency that's homeless should be discharged into homelessness.
Yeah, thanks, Louis. I agree completely. So I think that's something that we can definitely take back to our CAPE Health Equity Working Group. There is a CAPE position statement on supporting people experiencing homelessness in the emergency department, which was put out a couple of years ago by a number of folks on this call as well. And um, I believe there is one of the points is similar around that, but it's probably worthwhile for us to revisit and really maybe kind of spell out really specifically some of these like winter specific things that come up and also share back our best practices across the country. Thank you. Sahel, did you want to chime in?
Yeah, briefly, I know we're kind of at the end of time. I do think we need to move this discussion beyond kind of like emergency departments specifically. And I'd love to see if anybody had any thoughts in the last minute or two about that, because so much of this is because emergency departments, I think, have become de facto shelters, and we're patching things together to solve a problem that's, social, civic, political in nature, and very much kind of borrowed and inspired by the Hamilton model. I just wanted to briefly comment. Our hospital also had opened and has opened respite space that essentially people can use overnight, that we can discharge people to from the emerge department kind of between 9 p.m. and 7 a.m. Directly from the ED. And interestingly, even just being able to do that for a single night, for example, has made a big difference in our workflows and our capacity to uh, care for people and move people through. So, it makes a big impact to be not morally distressed and, like Britt said, like discharging people out to the street in the middle of the night. I think it creates huge moral distress for all of us, and it's a disservice to kind of all the care that we do provide. So, I know kind of late time, but would love to see how we move this discussion beyond the emerge.
That's great. I don't see any final sort of questions in the chat. Oh, thank you, Kate. So Kate's linked the CAPE statement around homelessness in the emergency department. So thank you, Kate. Um, in the interest of time and I'm not seeing any further questions, Elena, can you move to the next slide for us, please? Great. So this is sort of a really good way to kind of segue into, plugging people into some of the work that's going to hopefully continue to go on at the national level about this issue. Because yeah, that moral distress, as Britt sort of, brought up and others have echoed, is really sort of what sort of motivates us to do better and to see how we can continuously improve in serving this population. So the CAPE Health Equity Working Group is a working group. If you're a CAPE member, you can email CAPE Hanty at CAPE to join our list serve. We have our next working group meeting coming up on Tuesday, May the 19th. It's at 12 p.m. It's an online virtual meeting. We welcome anyone to join. If you haven't previously been a part of our meetings, please come join if you're a CAPE member. And then we're also going to be meeting in person at the Winnipeg conference in CAEP this upcoming June. So the details are there for the in-person meeting. There'll also be a call-in option to support some people to join us from a virtual perspective as well. Next slide. And then thanks again to Alina and the GEM Center for helping us host this virtual community of practice discussion today. And final slide, Elena, thank you. Please follow the link to the QR code, just a super brief evaluation about our discussion today. We'd love to hear from you about ideas for future community of practice sessions and to continue this conversation moving forward. So thanks again for your engagement. Thank you to all of our speakers from Hamilton, Toronto, Edmonton, and everyone for your engagement on this issue.